It's still morning. Good morning, everybody. I know we have a couple of House members that are on video with us. So I welcome them also. I'd like to thank all my members that got it together and decided to come to the Capitol. Thank you very much for joining us today. This is an important issue. And I'm glad to see everybody. You'd think we've been gone 2 years or something, but it really is good to see everybody. Didn't realize we'd be getting together again quite so soon, but I'm glad to see all of you. So welcome. I'll go ahead and say I'm glad to see the members that are sitting in the committee. I appreciate you coming and the expertise that you will present for us today. So let's get started. Amin Gandhi? Go ahead and pronounce it for me at the microphone.
Good morning. My name is Amy Gandhi, and I'm the team lead for the Viral Hepatitis and STD Epidemiology Program at the Georgia Department of Public Health. And I'm here today to present on our viral hepatitis elimination plan. So I did want to...
A question first, start off. When we started this, one of the emphasis was supposed to be HIV. Can you connect the two for me?
Yes. Do you want me to do it during the presentation, or
are you going to do the presentation? And does it connect why we're talking about viral hepatitis?
I can connect the co-infection.
I mean, I know what the connection is, but if you will do that for the committee as you go through the presentation.
Okay, absolutely. So before, as I talk about our elimination plan, which I believe all of you have a copy of, I did want to talk a little bit about sort of what viral hepatitis looks like in the state of Georgia. Georgia is one of 37 states that have been experiencing or have had experienced a hepatitis A outbreak since 2017. The outbreak here in Georgia began in June of 2018 and was officially declared over in March of this year. Currently, there's only 3 states across the country that are still experiencing an outbreak. This outbreak here in Georgia was driven primarily among those that use both injection and non-injection drugs, as well as clusters in men who have sex with men. It primarily affected the northern region of our state, as well as the Augusta area and the LaGrange area, and then Metro Atlanta counties as well. And officially, we declared outbreaks in 11 of our 18 health districts in the state. Since 2018, we've confirmed over 2,100 hepatitis A infections, with the median age of those infections being 45 years old. In these cases, we saw 64% of our cases were hospitalized, which is fairly unusual for hepatitis A. But because this outbreak was affecting vulnerable populations, we did have a higher hospitalization rate.
Excuse me just a minute. We're talking about hepatitis A?
Yes.
I guess in my mind, I just switched over to what usually we have is hepatitis C.
I'm going to talk about hepatitis C as well.
Okay, but this is hepatitis A is just highly infectious. Okay, and does it have the same effect as hepatitis C, where it's almost untreatable unless, or it's treatable?
No, so it's an acute infection. It runs its course, and you will develop immunity once you recover. Yes. Right. And I wanted to go over the data just to give a big picture, so it can kind of tie into our elimination plan. So with our outbreak, we did see a high rate of co-infection. About 3% of our cases were co-infected with hepatitis B. 13% of our cases were co-infected with hepatitis C. And for hepatitis C, in those cases that were among those using injection drugs, about 24% were co-infected with hepatitis C. And about 7% of those cases were co-infected with HIV. Geographically, as I mentioned earlier, our outbreak affected primarily those northern counties, as well as Metro Atlanta and the surrounding counties, including around the LaGrange area, Gainesville, Athens, and the Rome and Dalton areas. and then also the Augusta area. For hepatitis B, although we have an effective vaccination available, we continue to see acute hepatitis B cases, and those are newly acquired hepatitis B cases. A majority of these cases are primarily in those age 40 to 59 years of age. Those that are in their 20s and possibly 30s, if they were born here in the US, they were likely vaccinated as infants or children. So most of our new cases are among those over 40 years of age. However, we do still continue to see cases in those younger age groups as well. We also have a fairly high burden of chronic hepatitis B infections, as you can see on this slide as well. And as you read through our elimination plan, a lot of our activities and strategies in our plan do focus on increasing vaccination across the state, as well as testing in our populations. Geographically, the highest number of acute or newly acquired hepatitis B infections are in the metro Atlanta counties. However, if you look at it by rates by 100,000, the highest burden is in the southeast region of the state into central Georgia and our northern counties as well. If you look at our chronic hepatitis B infections, again, similarly, the highest number of chronic infections are in the metro Atlanta counties. However, if you look at prevalence rates across the state per 100,000, the majority of our chronic infections have the highest burden in the southeast region of the state into central Georgia and the counties surrounding metro Atlanta. With hepatitis C, we also continue to see acute or newly acquired hepatitis C infections. This is primarily among those that use injection drugs. And majority of the cases we see are in those that are age 40 or younger. I do want to point out in 2020, we'd had a change in the surveillance definition that we used, which allowed us to identify additional acute infections for hepatitis C. Hepatitis C, oftentimes when someone is infected, they are asymptomatic, so it's very difficult to identify an acute infection. So this has allowed us to identify additional cases. We estimate that for every one identified case, we're missing about 13 new hepatitis C infections. For chronic hepatitis C, we've also seen an increase in cases. The graph on the right for probable chronic hepatitis C cases are ones that we don't have complete laboratory information on. This may be for a number of reasons. It may be that only a screening antibody was done on patients and a viral load was never collected, or the viral load may have been negative, which is not currently reportable in the state of Georgia. And this ties into our elimination plan and sort of highlighting the importance of making sure that we're testing our patients with the universal testing recommendations that are currently out by CDC. And we have that theme throughout our plan to try to increase testing among our population across Georgia. Geographically, again, similar to hepatitis B, most of our cases are in the metro Atlanta counties and surrounding counties. However, if you look at the burden and rates per 100,000, you can see that the highest burden is in the southeast region of the state into central Georgia, as well as our northern counties. And similarly with chronic hepatitis C, majority of our cases are in the metro counties and surrounding counties as well. But if we look at the burden and rates per 100,000, you can see the highest burden being in that southeast region, again, into central Georgia and our northern counties. I do want to also talk some about perinatal hepatitis B and C as well. Our perinatal hepatitis B prevention program is a federally funded program that's been around since the mid-90s. So we do have a robust perinatal hepatitis B prevention program in our state. And in this program, we identify births to moms that are hepatitis B positive, and then track those pregnancies and then track those infants to ensure that they receive the birth dose of hepatitis B vaccine, as well as hepatitis B immune globulin. And then track to make sure they have the appropriate post-vaccination serology to show that they've developed immunity against hepatitis B. Since 2017, we have seen a decline in the state in births to moms that are infected with hepatitis B. In 2020, we identified 253 births to moms that are chronically infected with hepatitis B. And of those, 80 in that 2020 birth cohort, 83% did complete their post-vaccination serology testing and that showed immunity against hepatitis B. And we have not identified any infants that were perinatally infected with hepatitis B. Hepatitis C is a bit different than hepatitis B. There is no current national surveillance program for perinatal hepatitis C, but we do know that we're seeing an increase in infants that are being exposed to hepatitis C at birth, primarily, again, driven by the opioid epidemic and continued injection drug use. And for perinatal hepatitis C, many states don't track perinatal hepatitis C surveillance. Here in Georgia, we began doing passive surveillance in 2018. And in 2020, started doing active case management for infants that we identified that were exposed to hepatitis C at birth. In 2020, we identified 465 births to moms that had a hepatitis C positive history. Of these, only 171 had a documented viral load within a year of that infant's birth. So those 171 infants were case managed by our staff at Department of Public Health in our viral hepatitis program. Of these 171 births, 87 or 51% were tested appropriately and found to be not infected. 83 of these infants were not tested for a number of reasons. Either the parents did not follow up for testing or they may have moved out of state. We also find a lot of infants in foster care system or being adopted, so we're unable to track those infants. In our 2020 birth cohort, we did identify 2 infants that were perinatally infected with hepatitis C. So, that kind of gives a broad overview of what we're dealing with when it comes to viral hepatitis in the state of Georgia. So with that surveillance data, we developed almost a year ago, released a viral hepatitis elimination plan for the state of Georgia. And this plan is focused on 4 pillars for elimination. The first being surveillance and research, which is really focused on improving data quality and improving surveillance efforts so we have a better idea of what the burden of viral hepatitis is in Georgia, so we can inform prevention activities as well as policy. Under each one of these pillars there's a goal, specific objectives, strategies, and activities to reach elimination under these pillars. For surveillance and research, again, it focuses on improved data quality and increasing statewide capacity to be able to identify newly acquired hepatitis A, B, and C infections, as well as having a better idea of what the prevalence of chronic hepatitis B and chronic hepatitis C is in our state. It also focuses on standardizing priorities and protocols to ensure that we're conducting enhanced surveillance on these cases. And then ensuring data completeness, especially around demographics and the risk factors associated with these infections. And then there's also activities that focus on making sure that we're identifying strategies to better identify infants that are exposed to hepatitis B and hepatitis C at birth. The second pillar in our elimination plan focuses on prevention and education. We've taken sort of a play from the HIV handbook and focus on treatment as prevention as well. Trying to train and mentor providers across the state to increase treatment for hepatitis C, and a focus also on reducing the number of newly acquired hepatitis A, B, and C infections across the state. So there's a lot of focus on mentorship and training for providers to be able to provide hepatitis C treatment, especially with new, simplified treatment recommendations can easily be managed in a primary care setting. So we have a focus on primary care, substance use disorder providers to be able to treat hepatitis C. The third pillar is focused on policy, which is focused on reducing any barriers to accessing services and to increase capacity to address viral hepatitis. Many of the strategies and activities under this pillar focus on identifying those barriers statewide and identifying strategies to address those barriers. It includes, conducting cost analysis to determine what the resource needs would be to provide hepatitis C treatment across the state to those, especially to those that are uninsured or underinsured. And then also, identifying what the needs would be to sustain a robust surveillance program and perinatal hepatitis C surveillance program across the state. The fourth pillar is focused on medical care and treatment, which is focused on improving access to hepatitis B and C screening, linkage to care and treatment services. And this pillar, the goals, strategies, and activities really focus on increasing the number of providers across the state that are able to offer hepatitis A and B vaccination and B and C screening, treatment, and management. And it includes also developing mentorship programs for providers across the state, as well as pharmacists to promote vaccination and testing recommendations, and then promote treatment across the state as well. And we also, want to work with our harm reduction partners to increase those services. And, promoting some of the fourth pillar is focused on medical care and treatment. And that also includes, increasing prenatal testing for both hepatitis B and hepatitis C during each pregnancy. So as I mentioned, this plan was released almost a year ago, and we have had some, successes in reaching some of the strategies and objectives that are outlined in our plan. We've integrated enhanced surveillance within our program to ensure completeness of our surveillance data. This includes training and cross-training of our local district public health staff, providing progress reports so they know what the status is for their particular areas of the state. In August of 2022, we also implemented prenatal hepatitis B and hepatitis C screenings during each pregnancy, which is now required through the DPH regulations. Earlier this year, we also expanded the ADAP formulary to include hepatitis C medications for those that are receiving HIV care through Ryan White. And we're also implementing both in-person and virtual trainings to increase access to hepatitis C treatment statewide. And these trainings will target, again, primary care providers, substance use disorder providers, and other care providers that have the ability to provide hepatitis C treatment. And we also have a robust viral hepatitis ECHO program, which is a tele-mentoring program. We meet once a month. We currently have over 160 members with an average about 20 to 30 participants every month on each call. And these calls consist of about 20 to 30 minute didactic on a specific topic related to viral hepatitis, and then time for our partners to present cases and get recommendations and guidance from the ECHO community. However, there are many challenges as well to reaching elimination. We currently do not have any resources allocated specifically for viral hepatitis elimination, and it leads to limited public health capacity to enhance surveillance activities, support prevention and testing efforts, and increase our treatment capacity. We also have limited funding to conduct perinatal hepatitis C surveillance and case management. And there's also, barriers in accessing healthcare across the state for hepatitis B and C treatment, especially in rural areas of the state. Further, there's still a lack of insurance coverage and barriers with insurance coverage and restrictions. and then treatment restrictions for Medicaid recipients. As you can see on this map, Georgia has a grade C for Medicaid restrictions currently. Currently, prior authorization is still required. There are restrictions regarding retreatment as well. And then some managed care plans do require specific specialties to write prescriptions for hepatitis C medications. Okay, thank you so much.
I think we probably have questions. I would start it off with, okay, we started testing, we had an outbreak of hepatitis A, which is, it runs its course and is treatable. And you say that that is now at an end, the outbreak.
Yes.
Okay. Hepatitis B. Is hepatitis B treatable?
It is treatable for chronic infections. There's no cure for hepatitis B, but there are antivirals available to suppress the virus to where you're no longer infectious.
Okay, if hepatitis B is not treated, what are the physical consequences to it? What does it do to the body?
So it can lead to complications to the liver, such as cirrhosis. It's one of the leading causes of liver cancer in our country as well. Chronic hepatitis B and chronic hepatitis C are the leading causes of liver cancer in the US currently.
Okay. And always the one that was untreatable in the past has been hepatitis C. There's now a vaccine for it?
There's no vaccine for hepatitis C. However, there are treatments that are available that are nearly 100% cure rates with the available treatments currently.
For
And
C, but not for
C,
B.
yeah.
Okay, I'm having trouble hearing because of
That's
a
fine.
cold, those lasting effects of a cold. So this
problem.
may be something. What is our rate of hepatitis B? Give or take.
I don't have that in front of me, but I can definitely for
Okay.
chronic hepatitis B.
What about hepatitis C?
Our chronic hepatitis B case prevalence is underestimated. Nationally, we estimate about 2% of the population is infected with chronically infected with hepatitis C. But that's probably an underestimate again because lack of testing. And those estimates are based on certain populations.
That's the one you said if you test one person that's has hepatitis C, there's probably 13 undiagnosed
So that's for newly acquired infections.
newly acquired infections. And there is a medication for it now that used to be astronomically expensive. How is it now?
It's still expensive. However, there are patient assistance programs that can assist with the cost of treatment for the medications for anyone that may be uninsured. However, the barrier is still the cost of the doctor's visits and the labs and things like that. They still act as a barrier to accessing treatment.
Okay, and I'll end with this one and turn it over to the committee. Are both B and C mainly transferred sexually? Or is
So
that
hepatitis B can be transmitted through sexual exposure as well as blood exposure. Hepatitis C is blood exposure.
is
Blood exposure.
blood exposure?
Yes.
So needles and that kind of thing. Okay, thank you.
Mhm.
Let me go. I got a list here. Representative Hilton.
Thank you. Hello, there we go. Thank you, Madam Chair. Two quick questions. Number one, you mentioned the difficulty of screening for Hep C. Who do y'all partner with to help in that screening process?
So we, all of our health departments can do screening for hepatitis C. Our program also partners with some community partners to increase hepatitis C testing, especially in those populations that are at highest risk. We do a lot of work with Georgia Harm Reduction Coalition to increase testing, vaccination, as well as linkage to care. We also work very closely with another organization called Imagine Hope. And they are an organization that has integrated both HIV and hepatitis C testing in substance use disorder facilities, as well as medication assisted treatment facilities across the state. And we work very closely with them.
Perfect.
as well.
Last question on the 4 pillars of elimination. The third point is policy. Any policy recommendations or ideas or things that we ought to consider as a committee? I love the background music here.
Yeah, I think right now where we are as far as, looking at the activities that are identified in the plan, we're trying to identify some of the barriers and some of the challenges. As I mentioned, right now we have no resources allocated specifically for these elimination activities. We also don't have, we have very limited funding to do perinatal hepatitis C surveillance and case management. And I always say we can't think about elimination if we don't talk about or address the perinatal transmission of hepatitis C. So with the limited capacity that we currently have, that's why we focus on that very specific infants whose moms we know had a positive viral load during the pregnancy,
So
but we don't have the capacity.
It's more of a
to-
budget issue
yeah.
than a policy issue per se. If you had the resources, you'd be able to.
Right.
Yeah. Okay. Thank you.
Representative Fry?
Thank you, Madam Chair. Thanks for the presentation. I'm looking on the, I guess it might be the second or third slide where we have a population of confirmed HIV cases at 2155 and the co-infections below. Do you have the demographic data? Like it's a situation, just, I guess, answer this question for me. It's a situation where I think it's transferred by unprotected sex as well as drug use. Do we have a breakdown of the demographics socioeconomically, racially, and geographically of these cases? And that would give us an idea of where we need to focus efforts.
Sure. So hepatitis A is transmitted through fecal oral transmission, so ingesting contaminated fecal matter. For overall, as far as demographics, the outbreak did affect mostly whites. However, and especially in those that were identified in individuals that were using injection drugs, or both injection and non-injection drugs. It was primarily among whites and primarily in those between 20 to 50 years of age. Again, the median age was about 45 years of age. For HIV co-infection, 7% overall were co-infected with HIV. If we look specifically at risk factors and cases that were among men who have sex with men, the co-infection rate was about 51%. And then 2% among those that were using injection drugs. And those were primarily among Black MSM.
So that paints a good picture. Do you have the socioeconomic data to go along with those?
That's not data that we had collected.
Okay. But you do have the regional cases, I guess, exactly where they were
Yeah.
identified and can
Right.
focus on that.
Right.
Okay, thank you.
Welcome.
Representative Silcox?
Thank you, Madam Chair. Thank you for your presentation. I was curious, Georgia has grown so much since you started doing these studies. What percent do you think accounts for growth in the state? Because I know it's got to be hard to control since so many new people are coming into the state, that aren't necessarily educated about HIV or hepatitis, any of the types of hepatitis. So is there any of this attributed to the growth of the state?
I can't really speak on whether or not our increase in cases is due to the growth in population in this state. I can say the increase in cases could also be likely the CDC now recommends universal testing for both hepatitis B and C at least once in everyone's lifetime, unless there's potential risk exposures, and they do recommend routine testing. We've also seen an increase in testing because now CDC recommends, and we also require here in Georgia testing during each pregnancy. So that's also increased our numbers. But I can't speak on whether it's attributed to the growth of population.
While we're talking about testing, what is the test? What does it entail?
For hepatitis C?
Yeah.
So for hepatitis C, the testing is typically the first line of screening is for the hepatitis C antibody. And then we recommend that it's done reflex to the hepatitis C RNA, which is the viral load.
No, that's not what I'm
serology.
asking. I'm sorry, I'm not specific enough.
Sorry.
How do you get tested? What do you do? Is it blood? Do you have to take, I mean, which if you're out working with people out in the field that are living, just out in the environment, are they going to let you draw their blood if that's what it takes? I'm asking
Gotcha.
what's entailed to test somebody.
Okay, so it is a serology test, so it would have to be done by a provider that can draw serology. There is a rapid hepatitis C test that's a finger stick, but that's still a blood test, but it only tests for the antibody. So they would still need serology for the RNA testing the viral load.
What kind of results go ahead, Fry, Representative Fry, ask the question.
So the serology test, that is a blood drawn test
Yes.
from a phlebotomist.
Right.
Thank you.
What is how receptive are people that are addicts to letting you draw their blood and do this? I mean, are they finding real resistance to the testing out in the field?
So I think there could be some resistance just because of, the needle, the drawing of the blood. However, I mentioned earlier that we work closely with Imagine Hope. They've actually had a lot of their clients request hepatitis C testing because they've seen it in their circles. They've actually requested it. So I think it could go both ways. They could be very receptive because they know some of their, either drug sharing partners or people in their social circles that have hepatitis C, so they request testing. But there's definitely some barriers if there are some fears around having serology drawn. But I don't have a idea of how much of that is happening.
What's a round close figure to what that cost, the blood test and all?
So through public health, it's a little bit less expensive. For the antibody test, it's around really about $12, and then the RNA is around $50. If it's being sent to commercial labs, it could be a few $100s. So that's another challenge for those that are uninsured.
This Hope group you're talking about that's doing it, where do they get the funds? Are there federal funds? Are there state funds?
So they have, I can't speak exactly where all their funding comes from. I know they used to be what's a Gilead focus partner. So they were getting funding through Gilead to do it. I don't know if they still have that funding. I believe they also have a combination of state funding. And our program has also supported some of their testing through our resources in the past as well.
Okay, and Gilead is what?
It's a pharmaceutical
Company that is put out. Are we using our federally qualified health centers also? Are they doing testing?
They can be doing testing. I don't have an idea of how many are routinely testing their patients. Again, we are trying to do everything we can to promote the universal testing recommendations across the board.
Okay, Representative Reese.
Yes, thank you so much
Yep.
for the presentation and for the data. A few questions here. One, on graph after graph, I noticed a very high level of infections in Southeast Georgia, whether that was hepatitis A and C, acute HPV, and chronic HCV. And it seems to be very, from what I'm looking at, kind of abnormally high in some of these very rural counties. What is driving it? Are we seeing multiple infections at the same time? Like if someone is given hepatitis A, are they also possibly given hepatitis C at the same time? Can they run congruent? What's happening there?
So I don't know if they're necessarily getting it at the same time since they're both transmitted in different ways, but we did, on one of those slides where I showed the co-infection, we did have a very high co-infection rate of hepatitis C with hepatitis A. Hepatitis B and C can both be transmitted through blood. I think the increase in cases across the state, especially in the rural areas and in the younger age groups, is primarily driven through drug use. In the older age groups, there's a number. It could have been past drug use. It could have been blood exposure in other ways, whether it's, receiving blood, before our blood supply was being tested. It could have been for a various number of reasons. But the younger age groups and the newly acquired cases that we're seeing are primarily driven through drug use.
Through drug use.
Mhm.
Is there a particular new drug on the market maybe or something down there in Southeast Georgia that we are overlooking that's driving this number?
That's not something I can probably answer accurately. If there's a specific drug, I think it's the method of drug
Okay.
use.
And
that's
to
driving
the line of testing, Chairwoman Cooper, the avenue she was on there, I want to touch on that for a second. Are we utilizing like blood at the hospitals, like when individuals come into the emergency room or they come in to see a doctor? Are we partnering with groups to take advantage of blood that has already been drawn to just test it then to see if there's a presence of one of these that you've discussed today?
So through our program, we're not partnering with any hospitals to do routine testing on individuals that come in through like emergency departments. I know, for example, Grady Hospital is doing routine testing in their primary care clinics. I believe they may be testing in their emergency rooms as well. So some hospitals may be doing that. The challenge with that is if someone's coming in through the emergency room, making sure they're getting their results before they leave the hospital as well. But I know many health systems are incorporating it into their primary care settings.
Okay, thank you.
Representative Bennett.
Okay, here we go. Thank you, Madam Chair, and thank you for the presentation. I may have missed it. I have two questions. Did you say that routinely, the infant screenings, newborn screenings routinely are now doing hepatitis testing?
So for prenatal testing, so CDC recommends both hepatitis B and C testing during each pregnancy. And here in Georgia, we require it through our DPH regulations as well. During
That's
each
prenatal,
pregnancy.
thank you. But during the newborn screenings, do they also be testing the newborns at birth?
No, so for hepatitis B, they are not tested at birth. They're provided the birth dose of hepatitis B vaccination as well as hepatitis B immune globulin at birth. And then they finish the vaccine series to give them immunity. And the vaccine plus the immune globulin is highly effective in preventing infection in infants. And then they are later tested for immunity for hepatitis B if they are born to moms that are infected with hepatitis B. For hepatitis C, CDC actually just hot off the presses last week released testing recommendations for perinatally exposed infants, where they're tested between 2 to 6 months for viral load for hepatitis B if the mom was infected with hepatitis C.
Second question, thank you. Second question.
I'm here again. I can't hear. Worse than usual. All right. We are testing the babies only if the mom shows up in either case with B or C.
Yes.
So it's not every baby that is, or no. Okay. And that's the recommendation of the CDC, that we only test the ones that are. And
Right. As of now, the recommendation is to test those that we know were exposed at
Okay.
birth.
and the babies that are exposed automatically get medication and.
For hepatitis B, they should, that's what our perinatal hepatitis B prevention program does, to ensure that the OBs and the pediatricians are aware of the exposure. For hepatitis C, there is no medication to be given at
Right.
birth to prevent the infection.
But do they get that before they leave the hospital?
Yes.
They get the first dose of the medicine. And what did you say the follow-up rate was to get? Isn't there something where they have to get another injection? What is the follow-up rate?
I don't have those numbers in front of me, but for perinatal hepatitis B for our 2020 birth cohort, 83% of the infants did receive all of the follow-up testing required to show immunity after exposure.
Okay. Yeah. All right.
Yes, sir.
Did you say 6 months is a follow-up time for the second round of medications?
So it's the schedule for the hepatitis B vaccine is the first dose is given at birth. The second dose is given at 2 months, and then the third is given at 6 months.
And what
So-
about C, hepatitis C?
So there's no vaccination for hepatitis C. And there's no immune globulin, and there's no medication that can be given to prevent perinatal hepatitis C infection. It's just testing to find out.
Okay, and so you're telling me that on B, they get the first at birth and then they're supposed to get 2 more follow-ups. And are you saying that they, by the third follow-up, 83% of them had at least followed up to be tested?
So the testing is done at 9 months and then again at 12 months to show immunity.
Okay.
And for hepatitis C, the testing recommendation, again, there's no medications that can be, there's no vaccine, there's no immune globulin to prevent hepatitis C transmission in infants. But the testing recommendation is not a required testing. That's why our program kind of follows up on these patients, but they should be tested between 2 to 6 months.
Okay, so where does the mother go if they've been exposed and the baby gets the first dose in the hospital? How do they get the next 2 doses? Where do they go?
They can go to their pediatric provider. They
Okay.
can also go to the health department and receive the vaccinations.
Okay, one or the other. So they can go to our health departments and get the medication if they're not on an insurance
Right. Yes.
provider or something like that. So they have a source where they can get that if they follow up with it.
Yes.
Okay. Do we have any follow-up to see if people did this?
Yeah, so that's what our perinatal hepatitis B prevention program does. Each of the 18 health districts has a case manager specifically to track and follow these babies to ensure they receive the full vaccine series and the appropriate testing after.
Okay, we have a infant mortality rate which is very high. If you're not treated, what kind of problems does this occur? And is this one of our problems with infant mortality?
So we don't have good data, or there's not a lot around infant mortality related to hepatitis B and C infection. Again, with hepatitis B, we have highly effective precautions that are taken at birth to prevent infection. With hepatitis C, we don't have that. However, if we're able to test them early and get them linked to care, they can be managed. The treatments that are available for hepatitis C are approved for children 3 and over. So they could be treated as children. Of course, if they go untreated, they could lead to complications further in life, maybe cirrhosis or potentially liver cancer at an earlier age, potentially. But there's not a lot of data on mortality around perinatal hepatitis C infection.
Okay,
at this
and
time.
if we identify those children, if they can't afford private insurance, then they should be eligible for our Peach Care. And does
Assume
Peach Care
so.
provide the medications and the follow-up care for these children?
I can't answer that specifically. They should be covering at least the vaccinations for, I would assume, for
B.
hepatitis B. Okay.
I'll jump. Hey, everyone. Megan Andrews. Y'all know me. But yes, the Peach Care would pick up. There are prior authorizations and other kind of restrictions on access to some of the hepatitis treatments through Medicaid, but they do cover vaccinations and treatment for those children.
For the children?
Mhm.
Okay, thank you. Okay, sorry. Representative Dennessy, I'm sorry I'm so long getting to you. And Representative Oliver, you're next.
Thank you. Thank you, Madam Chairman. Thank you for your presentation. I know this is a intense conversation, I would say, to have. So thank you for the information you brought to us. I wanted to just thank you also for the work that you do in partnership with Imagine Hope. That money, to clarify, some of it does flow through the DBHDD budget to support hepatitis C testing and linkage to care programs that Imagine Hope operates all throughout our state. And they are being, they're having some very impactful results in that. It'd be good. I would maybe at another point, you might want to ask them to come in and discuss just briefly, what they do.
It's a good idea. You remind, okay. I think my new secretary, Andrea, is here. Lynn has been promoted and has gone to the appropriations department. Someday again, I'll speak to Matt Hatchett. That's the second secretary he's stolen from me. No, it's a good promotion and I'm very delighted for her, and y'all will enjoy having her in the appropriations area because she's a hard worker and great, but I'm looking forward for the committee to get to know Andrea well, and she'll do a good job for us. I run a training program for secretaries, apparently for Matt Hatchett. Okay, so as we go, and I'm teasing, I'm still speaking to Matt, of course. He's one of my favorite people. Representative Oliver.
Thank you, Matt. Thank you, Madam Chair.
Wait a minute, hang on, we'll get it.
Thank you, Madam Chair. You raised the issue that's on my mind. I'm reading that infant mortality and maternal mortality is increasing in Georgia. I wonder if you might consider having a discussion about that. What are the reasons for that? Perhaps when we're gathered together again.
Might be something we want to do. If we during special session, and y'all get ready. I'm gonna try to set up a meeting. Remind me not to explain to people how the legislative process works and how that they can lobby for a bill and work with a group to get it passed. We do have a group that wanted to know how they met their legislators, and they want assisted suicide. And I suggested that they join the Council on Aging. And they did. And the Council of Aging brings 2 or 3 proposals every year. And they're voted on by the members of that group. And that group of ladies that all live together in one of Senator Isaacson's son's areas. And they apparently lobbied very hard and got that group to pass that as one of their proposals. I have questions about it, so I thought that maybe during the special session, we would have let those ladies come and talk to y'all about it. So I'm trying to set that up, and rather than having a bill, as I have asked people, there doesn't seem to be a lot of interest in having a bill like that. That may be different after the committee, but I thought I would show them, out of respect for all the work in the council, that I would at least give them a hearing, and that y'all could very nicely tell them where you stand on it rather than go with the bill and go to a full committee. So get ready. So we have a list of things that, maybe we'll spend a couple of days doing to pass our time in redistricting. And Representative, we're going back to, no, all right, Representative Bennett, you had another question?
Last question, Madam Chair. Thank you. I'm just curious as to why there's such a disparity between the treatment and the post-treatment and the follow-up for infants with hepatitis B versus hepatitis C.
So the perinatal hepatitis B prevention program is a federally funded program that's been around since the 90s. So it is, very well funded through our federal partners. There's currently no federal funding available for perinatal hepatitis. There's not a similar program for perinatal hepatitis C. Many states don't do any surveillance or case management around perinatal hepatitis C. We've taken that initiative in our program because we saw an increase in infants being reported to us, and we wanted to kind of get a better idea of what the burden would be here in the state.
Representative Reese?
Yes, thank you, Madam Chairman. Quick follow-up. I want to talk about the restrictions. I think the young lady, she sat down again. What's her? You come back. Still consider myself one of the new guys. What's your name?
I'm
Who are you?
Megan Andrews. I'm the Assistant Commissioner for Policy at DPH.
Excellent.
Yep.
Okay. Well, as far as the restrictions, I think there are some sobriety issues too there when it comes to Medicaid. But when you look at the free for service plans, many of those restrictions have been removed. Do you think that's a big issue? Should we be advocating to have those restrictions moved from Medicaid so that you guys can move faster and move quicker? Like, how much of a backlog is that causing?
Yeah, I mean, it's definitely a burden to access to care. There's a really great report that I'm actually I'll pull and we'll email to you that explains why Georgia was rated C as far as Medicaid restrictions for access to hepatitis medications. And that'll kind of give you some ideas about what restrictions are out there that may be a good conversation to have with
So is that
Medicaid.
something we can impact, or is that on the federal level?
No, it's state
state.
driven by the
Okay.
Medicaid program. Mhm.
Okay. All right. Thank
Thank you. Then we'll look forward to that report. Is it coming soon, Megan?
Yes, Graham will email it after the meeting.
Oh, okay. And we can get it. Okay. Because I mean, since that is something that we could look at and, perhaps lobby for changes. Representative Howard.
Thank you, Madam Chairman, and thank you for your presentation as well. I was trying to see, I see some low numbers as it relates to infants completed and how many folk at birth, they're like 171. Those seem like low numbers. What is the surveillance process? And I noticed that's one of your pillars, surveillance and research. Are you talking about increasing surveillance? And if so, what does that look like? Do we just test folk that come to the doctor, folk that have symptoms? How do we come up with that research to get to where you're trying to go with as it relates to policy?
So are you just for clarification, are you asking for hepatitis C testing in general or for the perinatal?
In general.
In general. So, I think one of the biggest things that we're trying to work on and promote across the state with our providers is universal testing. I think a big issue is that those testing recommendations aren't actually happening necessarily. I think in some settings, they likely are being routinely or offered testing to all of their patient population. So we're trying to promote and make sure that we're promoting the CDC recommendations that everyone over age of 18 is tested at least once in their lifetime for hepatitis C. And they're not only tested, but also reflexing to that viral load so we can actually get an idea of what their current infection status is for hepatitis C. And then promote routine testing for those individuals that may have continued risk exposures.
And it's a brief follow-up. Are there any estimates of maybe unreported cases that got through the system that are not in these stats?
If all positive hepatitis C lab results are reportable in the state of Georgia. We don't currently have negative lab reporting, so we can't get I don't have necessarily an idea of what the testing rate looks like versus positivity rate. But if it's a positive result, it should be getting reported in our system.
Okay, if I move on, I'm going to make Darlene Taylor, Representative Taylor is online. Darlene, you get the last question on this, and I've added to how long this has taken. We have a lot of other presenters. If you'll not repeat anything that's already been presented, but just, get the very specific things out to us when we go on. What you need, Darlene? Glad to have you on with us.
Well, good morning. I'm happy to be able to participate. I just had a question. Can any person go to a health department and request the testing? Is this something that has to be requested by a doctor, or can someone just go in and avail those services at the department?
Yes, anyone who should be able to go to any of our health departments across the state and request hepatitis C testing, as well as hepatitis B testing.
That take care of your question?
It did. Thank you very much.
Okay. Thank you very much for a good presentation and letting us pick your brain.
You're
And I
welcome.
really
Thank you.
appreciate it. Thank you. All right, moving on, we have Dr. Jenna Gettings.
Madam Chair, with your permission, we'd like to have Kirsten go first.
Sure.
Perfect.
Kristen Oliver.
Kirsten Oliver.
Kirsten, I'm sorry.
Sorry, it's easy to misspell. It's fine. But good morning. My name is Kirsten Oliver, and I'm the epidemiologist for the STD program here in Georgia for DPH. And today we'll just review sexually transmitted diseases in Georgia. Okay, and as Amy also defined that there are notifiable diseases in Georgia, and for specific STDs, we have syphilis, which include congenital and adult syphilis. And we also have syphilis during pregnancy, which is referred to as congenital syphilis. And for our other remaining reportable STDs, we have chancroid, chlamydia, gonorrhea, and lymphogranuloma venereum. And within the state of Georgia, we have not seen any cases of chancroid or LGV in the state of Georgia since 2012. And for our remaining reportable diseases for both congenital syphilis and syphilis during pregnancy, that is reportable immediately. And I'm sorry, is there a question? Oh, okay, sorry. And for chlamydia and gonorrhea, those are reportable within 7 days. And for state, oh no, ma'am, we'll see later in the presentation. But for state level epidemiologists, which include myself, we must ensure that all cases are accurately counted within the state once they're submitted to CDC. And within that process of accurate counts, that just makes sure, you know, we don't report any duplicative cases or anyone that isn't considered positive by our testing regulations. And CDC establishes that closeout date for us every year. And for this year, it was this past August. Okay. And then for our testing recommendations, CDC requires or they promote testing recommendations and they vary by disease. Sorry for being so tongue-tied this morning. And STD testing is recommended for anyone with a sexual partner who has an STD. But some of our populations that we focus on include women under 25 who are sexually active, women over 25 who are sexually active, and if they're at increased risk of STDs. And we also include all pregnant women, sexually active men who have sex with men, and persons with HIV. And with the link you can see here in the presentation, that just takes you to more testing recommendations for our different populations of interest. And for STD treatment, persons infected with STDs need prompt, appropriate treatment, and these prevent adverse outcomes for those extended periods of time that someone is infected with an STD. And it also prevents infection of others, so their sexual partners and things like that. And partners of infected persons must also be treated because, again, it prevents infection for anyone, and that can go back to the original patient who infected the person. So it can limit reinfection in that person. And it also prevents those adverse outcomes for the partners, and it limits the chain of infection. And as we talk about STD treatment, I also wanted to mention expedited partner therapy. And kind of the short version of this is we'll see positive cases of chlamydia and gonorrhea in patients. And instead of that partner having to go to the doctor to go ahead and get tested and receive treatment, we also will send, that original infected person with medication for their partner. So it kind of cuts out that middleman, and it increases the rate of treatment and decreases the rate of infection for their partners.
That means the partner doesn't have to admit that he has it or she has it. They can
Yes,
just
ma'am.
quietly take the medicine and
Yes, ma'am.
get
Exactly.
right.
And just a small statistic with that, we do see, according to CDC, that 29% of those who receive EPT are less likely to be reinfected than those who were simply told by their partners to go to the doctor. So it just increases the efficacy of treatment for everybody. And we also have a list of those who support EPT therapy, or expedited partner therapy throughout the state. And you can see those listed on the slides as well. Okay, and to just get into some statistics about our data, the current slide is showing our Georgia STD rates versus the national rates across the country. And this is between 2018 and 2022. And as you can see, we can see the rate of STDs increasing if we compare our baseline point of 2018 going into 2022. And I should also mention that Georgia, any statistics we see in our presentation are provisional and they're subjected to change. So these are just some snapshots that we have, but our data is being finalized as we speak. And again, as you can see, in comparison with the US rate, Georgia is usually just above that. And for both, we see rates increasing over time. Okay, and our next slide are just our STD, case counts for the state of Georgia between 2017 and 2022. And as you can see, our actual case counts for STDs have increased since 2017. And you can see that vary by disease. And I just wanted to make a note that syphilis also includes congenital syphilis cases. And those are the children who were born with syphilis. Alrighty, and then our next slide is just showing a demographic geological breakdown of where we see our 3 reportable diseases throughout the state. So on the left-hand side, you can see chlamydia. In our middle map, you can see gonorrhea. And on our far right, you can see primary and secondary syphilis for 2022. And if you just kind of look at the color coding, the darker the public health district, and I forgot to mention, these are by public health districts. So the darker the color, the higher the rates are within that public health district. And throughout the map, you can see that these are some of our more urban areas. So we see the Metro Atlanta area with counties such as DeKalb and Clayton, but we also see other urban counties such as Columbus, Augusta, places like that. All right, and then we'll just get into some more demographic breakdowns of our data. And you can see for chlamydia and gonorrhea, those are primarily diagnosed in people of younger ages. So if you look on your left-hand side, you see our distribution, our age distribution pie chart for chlamydia, and on the right-hand side, gonorrhea. And again, you can see that these are more in younger ages than those over 30. And then if we get into our syphilis chart, sorry, just trying to catch up with my notes here. You can see for our slide here, we have the different stages of syphilis displayed. So if you see on your far left-hand side, you see primary and secondary syphilis. And these are usually the most infectious stages of syphilis that show symptoms such as chancres or sores within the reproductive organs. And then you'll just experience other things like rashes and just some other apparent symptoms. And for our stage of early non-primary, non-secondary syphilis, and also our late or unknown duration of syphilis, there are no symptoms associated with this. And specifically with early non-primary, non-secondary syphilis, we know that there are no symptoms, but the infection most likely occurred within the last 12 months. And then with unknown or late duration syphilis, there is no evidence that exposure happened within the last 12 months. And in our chart, you can see that these differ from our chlamydia and gonorrhea charts, where we see these are affecting people of older ages versus those of younger ages. Excuse me. And then now we're getting into the gender breakdown of these STDs. And again, on the left, we can see our chart, our pie chart for chlamydia. And on our right-hand side, we see for gonorrhea. And in this case, we see more cases of female gonorrhea, or excuse me, female cases of chlamydia versus we see more cases of gonorrhea in males throughout the state. And again, the percentages based on the note on the slide are reflective of those where sex was known. Okay, and we can see another gender distribution charts here, and these are for our stages of syphilis and for each stage of syphilis. And we see this also nationally, that most cases are male throughout the state. And this follows what we've seen historically throughout the state for about the last decade or so. Okay, and then for some other risk factor information that I'm going to review, there is a process for case reporting with STDs, and within that we try to get an interview with our patients, but unfortunately some of our patients can decline or just refuse to answer those interviews. So the statistics you see here are for those who successfully completed their interview during their STD case form. And we can see that about 40% of those did answer yes to drug use. About 37% of those specified that they were using alcohol specifically. And then for sex with an anonymous partner, we see again about 32% of interview cases did answer yes to that. And then about 29% answered yes to having intercourse while drunk or high. Okay, and then we're just going to get into some quick congenital syphilis numbers. And again, these are for children who were born positive with syphilis. And as you can see, unfortunately, our numbers have increased since 2017. And so that's just to give you a quick overview of the figure itself. And then here we have actually our rate of disease, and we have to break down this chart a little bit. So if you look at the blue and the red bars, these are the rate of syphilis in females, specifically in those of reproductive age, which we define as ages 15 to 44. And if you look at our axis on the far left, that only shows the rates for the population that I just mentioned. The syphilis for all, for females, for all levels of syphilis is the blue bars, and then the red bars are for primary and secondary syphilis levels. And if we just follow the trends over to the right, we see that both have increased for women. And then if you take a look at the gray bar that we see as kind of the line above that, and we look at the axis on your right-hand side, which shows the congenital syphilis rate and how that rises, we also see an increase in that. So for syphilis in females of all stages, and for primary and secondary syphilis, and for congenital syphilis, we definitely see a rise happening. And this is in comparison of our rates in 2017 and our rates in 2022. Okay, and similar to what Amy mentioned in her hepatitis elimination program, there are some things that we have in place for prevention of congenital syphilis specifically. And since 2019, we've looked at what we call missed opportunities for prevention for congenital syphilis. And this does have to do with testing of the mother and the baby during gestation, so during the woman's pregnancy. And we have our different categories here of what we consider to be missed opportunities. So in the blue bar, we see that these are women with no prenatal care. So they never made it into their doctor's office, never got tested, because in the state of Georgia, we do recommend testing at the first prenatal care visit, the third trimester visit, and upon birth. But we're just looking at numbers from 2020, so we can just see how we're getting there now. So as I mentioned, for the blue bars, we see that as no prenatal care. So this woman never entered kind of the medical environment for her baby to get any kind of care. And we can see that that has unfortunately increased since 2022. But as I said, these are prevention efforts that have started in 2019. So we're still just kind of, just letting it kind of work itself out to see how we can watch these numbers decrease. And then for our second category, you see, which is prenatal care. So that first touch base of the mother coming in to her doctor's appointment, and for her to get tested for syphilis at that point in time. And I have a special note that says no third trimester test between 28 and 32 weeks, because it's assumed that if the mother is tested at that first prenatal care visit and she doesn't come up positive anymore, then there shouldn't be another test to happen after that. And then for that, we can see that that did stay at the same level for 2020 and 2021, but we're also seeing increases for that. So we're hoping to see good news for that in the future. And then for our third category here, which is infected after third trimester test. So this is when the mother may have been seen during her prenatal care visit, but she may have become infected somewhere in between that first doctor's visit and this third trimester test visit. And so again, these are just hurdles for us to see, okay, we might have missed someone during that first prenatal care visit. So now we're trying to get them through during the third one. But unfortunately, because of this category named infected during third trimester test, the mother is then given treatment so we can still prevent the baby actually being born with syphilis. And again, looking at our charts for comparing 2020 through 2022, we have seen that increase in 2021, but it decreased in 2022. And then for our final category, which is inadequate treatment or treatment within 30 days of delivery, this is for a mom who didn't get treated anytime during her pregnancy, where we might have missed it through any type of diagnostic test. And unfortunately, the child was born with syphilis at this point in time, but still we're able to treat this mother within 30 days of delivery, as well as the baby, which will then let us know that, okay, we caught this child, we can still treat them, whereas they won't develop as a case. And then again, just for some more congenital syphilis prevention, these are the testing and treatment requirements that are present in the state of Georgia right now. So again, if we just kind of break down the chart really quickly, for that first level for prenatal syphilis test at first prenatal visit and 28 to 32 weeks gestation. Again, this is for that initial visit for the mom to their OBGYN for them to get tested and treatment at that point in time. And we see that that is the best way for us to prevent congenital syphilis cases from that first doctor's appointment. And then within the rest of the chart that we'll just kind of breeze through really quick, it just gives recommendations for adequate treatment for those of late and unknown duration of syphilis, as well as those who were treated 30 days prior to delivery. So still kind of a late catch, but we're still able to treat them where we can prevent this case from happening. And then our bottom row here is just detailing the type of treatment that's recommended for syphilis. And currently penicillin G is the only known effective antimicrobial, for treating fetal infection and preventing congenital syphilis. So this is what's recommended from CDC to all these mothers. And there is alternative treatment available in case someone is allergic to penicillin. So there is just alternatives just to make sure that we're treating these women and their children appropriately. And also our last point is documented syphilis treatment. And we state that women without a history of treatment should have syphilis stage determined and should be treated accordingly to their penicillin regimen. So this is if, in case a woman comes in and they've never gotten treated, never saw an infection for syphilis within our notifiable system, but we're still looking for documentation. So if we don't have it documented, but we know your current stage, we're still going to treat you for that appropriate stage of syphilis. And if there are any questions.
I've got one too.
Okay.
And we'll try to keep them at a minimum, but okay, I'm probably going to ask the one that everybody's right. Just wanted to ask. First of all, I'm going way back to my nurses training. Does congenital syphilis undiagnosed, are we seeing baby born with severe congenital problems?
Yes,
Or-
ma'am, we can, I'm sorry. Okay, yes, we can. And unfortunately, one of the outcomes for this could be stillborn births as
Okay.
well. So
And could lead to, that was, that could be part of our stillborn or early infant death.
yes, ma'am.
Okay. So one of the things about it, and the other thing is, why is it going up so much and everything we saw?
And it's just for transmission and just higher rates of, we're just seeing more and more people, engaging in sexual activity, and they may or may not be as safe as possible from the recommendations that were given, but
Okay. We are a rapidly growing state. Does any of this correlate to, here again, back to that question, that we are adding citizens so quickly? Is that rate, or has anybody correlated that between
us-
our fast growth?
no, ma'am, within the STD program, I can't say that we have recently.
Where do we stand with the other states?
Well, with CDC, annually with their STD report, they do release state rankings throughout the country. So they'll rank you based on the severity of what you have for your disease level in comparison to everyone else. And I can't speak to it right now, but I believe for syphilis, we were about 16th, but I want to say for congenital syphilis, we were somewhere in the top 10, I believe. And again, I can get these more concrete.
So that
figures
was
later.
once that the smaller numbers were not positive.
Yes, ma'am.
Right.
Mhm.
Jeez. We're always on the low part, and then when it needs to be on the other, we're always backwards. Okay, who we got? Representative Hutchinson.
Thank you, Madam Chair. I had two questions very similar to what Madam Chair asked. Is there any data-driven reasons why we're always higher than the national average? And second is, in your opinion, what can we do to address that to get our numbers down?
So in terms of why we're always the highest, for STDs within the Southeastern United States, we do have more elevated numbers when compared to others in the country. And I can't think of right now why that is because my brain is a little scrambled, but I can definitely get you that information, or Graham or Megan can definitely get you that
Okay,
information.
let me add Shelley's question. Is there a difference in the way, like when we count the number of maternal mortality, some states only go out and count their days for 60 days post-delivery. We count a whole year. So we can have a big discrepancy on the number of maternal mortalities compared to other states that only, count it if you die within 60 days after delivery. We go out a whole year. If you die within a year, and our group that meets to decide if that was really due to a pregnancy, we count a whole year, and that really throws it off. Is there a difference in the way states decide about our amounts?
Yeah, so, and y'all may recall, this bill actually passed through your committee this past session, Senate Bill 46, that brought Georgia's prenatal testing requirements for syphilis in line with CDC recommendations, which was new. And that is, as Kirsten mentioned, the testing at the first visit, the third trimester testing, and then also because Georgia is such a high burden state, we require testing at delivery. Not every state requires that. So the more you test, right, this goes back to, it reminds me of COVID. The more you test, the more you're going to find. So I can't speak to what our neighboring states, if they follow those CDC recommendations or not, we can get you that information, but certainly the more you test, your numbers are going to be higher.
Shelley, do you have another question? No, that's it.
I did want to see your opinion on what we can do to lower those numbers.
Yes, yeah, absolutely. And testing is for congenital syphilis specifically, testing is a great way to do that because there is a treatment to prevent it. So that bill just went into effect July 1st. This data is from 2020. So we're not quite caught up. There's always a data lag. We're not caught up to see the effects of that legislation. And, we did a lot of training with hospitals, the delivery facilities and providers to make sure they're educated on this, but there's more work to be done. People are learning a new requirement. So we'll continue with that education and promoting testing at those intervals because really that third trimester test, you're going to catch women and be able to treat them before delivery to prevent those numbers from going up.
Well, and I think that one of the things that would pointed out by the graph, and we moved quickly and did a good presentation, is if we can get mothers to get prenatal care earlier, you notice the lack of prenatal care with people walking in and getting their first prenatal care visit when they're 38 weeks pregnant, 40s when you deliver, or they would like you to deliver at 40.
Right.
So I will tell you that Milledgeville has started a new nurse midwifery program. They are doing what they need to do. At least many of their classes, over half of the first one, were mature nurses with experience that were coming back to take the midwifery program and going back to their rural Georgia towns where they lived again. So if we can get a program going where even if they don't have a physician, if we can have like a center and spokes where the nurse midwives do the prenatal care and work out some kind of program like that, we can at least maybe decrease infant mortality and maternal mortality. So there's only one nurse, before this, there was only one nurse midwifery program in the state, and it was in Emory. So Milledgeville stepped forward and decided they would start one, and it's being effective. I think they're on their second, maybe their third class. So we will be coming to ask you to help maybe with the money. One of the problems they're having are preceptorships, finding enough doctors wherever they go that are willing to do the training. It takes time. Rural doctors are very busy, and it would help them with a little bit of reimbursement to do the training if they would take them. So we're looking for money that's already in the budget or already out there for programs, but might be coming back to the legislature. Okay, who we got? Representative Fry.
Thank you, Madam Chair. Y'all, thanks for the work you're doing and the information you're bringing up. I appreciate it. One of the things the question I had, and the idea that it seems like the youth are affected. It's a younger age. Do we have any sort of curriculum? Are we teaching our kids this? I feel like I grew up seeing some crazy pictures of stuff, and it really sticks in your head. And is there a school curriculum that y'all are participating in, getting this information to our youth? And I think if they really understood what was going to happen, we might see our rates go down a little bit.
Yeah, there is a education program through DOE. It's going to vary a little bit depending on the part of the state you're in, based on driven by local factors as far as, how you speak to the children. But we do partner with the schools and youth to provide services in our health department for those younger patients that need help. We do offer those services to them too, and try to get out and provide education. But, I think school education is certainly important, but it is a sensitive subject with parental control and all of that.
Thank you, Madam Chair. I think one of the things that really stood out to me was the fact that older people are older 40 plus are having early non-primary syphilis and late or unknown duration syphilis. And my question is, how do they get to that point where they've gone through however age they are and not know that they have syphilis?
Sure. So with primary and secondary syphilis, those are more the symptomatic stages of syphilis. So where you'll see some of those nasty things that we're talking about with the sores and things. But once we get into that early non-primary, non-secondary level, that's where it's asymptomatic, where we can tell that someone wasn't exposed within the last 12 months, but they don't experience any of the rashes, sores, or anything like that. So that can actually exist in the body for an extended period of time before there even noticeable changes. And there are adverse effects of these later stages of syphilis. So there are neurological issues. Someone could have optic or ear issues associated with that. But more often than not, they'll come in to get tested for something else, and then they'll kind of discover that they have these later stages of syphilis. So that's where we kind of see those population groups explode in our numbers a little bit.
Representative Jenner, have you seen the billboards that say if you're 60, I think it say if you're 62 years of age or older, you need to get tested? There's one that's just that center. I think there's a lot after the Vietnam War and that era where people got syphilis. They didn't, they had a little bit of, in the first stage of symptoms, and then it goes totally undetected. My first patient in nursing school was an elderly gentleman with the late stage syphilis with walking problems and neurological problems. And let me tell you, the first penicillin injection I tried to give him didn't go well either. I will never forget that experience, but it does go undetected, and it has very serious effects in the later stages. And we could be seeing that in our Medicaid population because of undetected from that time. But there was a big campaign from somebody, federal, because I used to see the billboards that said, get tested. You needed to be tested for syphilis. Thank you very much for our program, and we'll move on. Okay. Do you all want the next person to be Dr. Jenna Gettys? Okay.
All right, I'll jump right in. So I'm Jenna Gettys. I'm the HIV Epidemiology Director at DPH. So today I just wanted to give an overview of our most up-to-date finalized data, which is 2021. We're currently wrapping up 2022, and the reports for that will be available spring of next year. And so I'm going to be presenting data both on prevalence of people with HIV in Georgia, as well as incidence, which is new HIV diagnoses. We look at both of these factors because the new HIV diagnosis surveillance really gives an idea of trends and who's newly being exposed and infected, whereas the prevalence data allows us to evaluate our care continuum, which I'll be touching on, as well as the perinatal HIV transmissions. So to provide you with some national context, shown here is the map of the US for rates of HIV diagnoses among persons 13 years and older. And Georgia is ranked third highest for rates of people with HIV, behind DC and New York. So overall, in 2021, we had 61,518 people with HIV living in Georgia. So the predominant demographics for this group were 75% were male, 68% were Black, non-Hispanic people, 62% had an infection attributed to male-to-male sexual contact, and 44% were the ages 50 and older, which is a reflection of increased life expectancy given the availability and access to treatment. So this map shows the rate of people with HIV by health district. So the darker purple colors represent higher rates of people living with HIV, while the light yellow colors is the lower incidence. And as you can see, our 3 highest public health districts are Fulton, DeKalb, and Clayton, while the Northern Health District have the lowest rates of people living with HIV. So now I'm going to switch gears and talk about new HIV diagnoses. So again, to give you national context, this map shows the rates of diagnoses among those 13 years and older within the US, and Georgia is second highest rate, second only to Washington, DC. And in 2021, we had 2,412 new HIV diagnoses. And now I'm going to do a demographic breakdown of that. So for age at diagnosis, 68% of individuals were between the ages of 20 and 39. 71% were Black or African American, 15% were white, 10% were Hispanic or Latino. 78% were male, and 68% had infections attributed to male sexual contact, 27% heterosexual contact, and just 3% were attributed to injection drug use. So you can see overall, this population closely matches the population of people living with HIV with the exception of age. So shown here is how the rate of new HIV diagnoses has been changing over time in the solid green line. So overall, we have been seeing a decrease. And when you look at the change from 2014 to 2021, we did see a 19% decrease, but I want to take an opportunity to show the impact of the COVID-19 pandemic on these diagnoses, because it's important to consider when we are looking at data moving forward from here. So in 2020, we saw a big decrease in HIV diagnoses, shown with the red arrow. We believe this is mostly impacted by access to HIV testing services, as well as changes in healthcare seeking behaviors. And as of 2021, we are starting to see this level return to pre-pandemic levels, shown with the yellow arrow. But based on the trends that we're evaluating, we still believe that there's an excess of missed diagnoses. So we have people that normally would have been diagnosed in 2020 or 2021 that may still have not been yet diagnosed. So to give you a better representation of what the real trend might be, we look at the data from 2014 to 2019 prior to the pandemic, and we saw a 5% decrease. And you can certainly see differences among different subgroups in these trends. So now looking here at where individuals with diagnoses comparing the Atlanta MSA or Metropolitan Statistical Area to see the rates in the metro counties versus non-metro. We see that 66% of people diagnosed with HIV were within the Atlanta MSA compared to 17 new diagnoses per 100,000 in the non-metro area. And to provide a more granular view of this, again, this is the rate of new HIV diagnoses by public health district. And you can see that Fulton, DeKalb, and Clayton by far have the highest rates of new HIV diagnoses. And again, the lowest rates are in the Northern Health Districts. So now I'm going to shift gears and present briefly on the HIV care continuum measures. This is the way that we evaluate how well people with HIV are able to access HIV care services. We primarily follow 4 different measures. The first is linkage to care in 30 days after diagnosis. So this is only evaluated for people who are newly diagnosed with HIV. The remaining 3, we evaluate anyone who was diagnosed with HIV prior to the evaluation year. So for engagement in care, they had at least 1 HIV care visit during the calendar year. Retention in care, they had at least 2 care visits more than 3 months apart within the calendar year. And then the final measure is viral suppression, which is our ultimate outcome. So if an individual is considered virally suppressed, they had their most recent lab was suppressed within that calendar year. And this is especially important because individuals who are suppressed are healthier and they're unable to transmit HIV. So I'm going to show the overall measures for Georgia for all four, but I'm going to focus on viral suppression as far as the demographics. So overall for Georgia, the HIV care continuum in 2021, for those newly diagnosed with HIV, we saw 83% linked to care within 30 days. Among those who had been diagnosed prior to 2021, 71% had at least one visit during 2021. 52% were retained in care, meaning they had at least 2 visits. And then overall, 60% were considered virally suppressed within 2021. I also indicated on the slide an asterisk at the 95% mark for both linkage care and viral suppression. These are the goals for the National HIV/AIDS Strategy, which is a plan put out by the White House for ending the HIV epidemic by 2030. They recommend that 95% of individuals are linked to care within 30 days and that 95% of people with HIV are virally suppressed. And I'll also note that Georgia is in the bottom quartile of all the states for both engagement in care and viral suppression. So this is a busy slide, but it is showing the proportion of people who are virally suppressed by the different demographics. So at the top is the overall at 60%. Then you have age in orange, race and ethnicity in purple, gender in red, and transmission category in green. And then there's a gray dashed line that allows you to see the groups that are faring better for viral suppression than the ones that are doing poor compared to the other groups. So as far as those groups that are doing better, we see good viral suppression, or good is relative, but among these subgroups, we see better viral suppression among older age groups, 50 to 59, whites, and men who have sex with men. Comparatively, we see lower viral suppression among younger age groups. Hispanic and Latino, Black, and African Americans fare worse with viral suppression compared to whites, as well as those with infections attributed to injection drug use. So my final slide here is for perinatal HIV transmissions. So this graph shows the number of perinatal HIV transmissions by year. The different shades of red just indicate whether that was the baby was born within metropolitan Atlanta versus non-metropolitan. So in general, we are seeing a decline in the number of perinatal HIV transmissions. In the last few years, we've only had 1 or 2 reported each year. So it was somewhere around 2014 or 2016, there was enhanced effort to educate on perinatal HIV transmissions, and you can see the impact of that here. And that is it for me.
Didn't we pass we passed a bill on HIV testing that lowered the number, right?
Yeah, I believe it was around that time frame where you did the prenatal testing requirements that then you piggybacked on for the syphilis.
Right.
Yep.
Because not only it was bad for the mother and the baby not be diagnosed, but it was also putting staff members and everybody working in the delivery room and the nursing nurses with them at risk of infections. And we passed that bill. And I think that time there was about 20 or something that year, babies born with it or something. So I'm glad to know it's down to 1 or 2. Wish it was 0. So thank you to all that were here that helped pass that bill. Okay, other questions? Who I got? Representative Frye.
Thank you, Madam Chair. I've just really got to bring this up again. I really feel like I'd love to see an overlay of these sexually transmitted diseases versus the curriculums that they're allowed to present to the students in the schools, as well as the difference in the education, whether it's a private school or a public education school. I'm not necessarily asking anybody to do some more work, but I think that that would really reveal the target areas that we need to focus on and the policies we need to focus on as far as the education around this.
Yes, certainly. And I'm happy to get with DOE to see if they have a breakdown perhaps of what some of their school districts are doing, if they're using like a national program or things like that. So we can get with DOE and pull that for you.
That would be great. Thank you very much. And you know, you think about the idea that poverty, the number one indicator of poverty is going to be teenage pregnancy. And when you alleviate the teenage pregnancy, you can go ahead and you really make an effect on the outcomes of poverty as their time grows on. And I certainly would believe that this would be directly related to some of that, where if we increase access to birth control to our young folks and teach them about this stuff, those things are going to go away. They're going to go down, the numbers decrease. And I think that's extremely important to focus on, because it's creating problems and burdens on our healthcare system because we refuse to let the young people know the dangers of the things that they may engage in. And that's an important policy decision that I think the state should take a look at seriously. But thank you.
Yes, certainly. Thank you.
Representative Reese.
Thank you, Madam Chair. Did I understand this right? That 71% of the 2021 HIV cases are Black African American.
Yes.
That's a problem. That's a huge problem. Not that I want the burden to be shared with other races. Let me be clear, because I don't want the wrong headline coming out about this. What I'm saying is it's extremely problematic that 71% of the African American community, which is why I consistently stress testing. And I think I said it earlier in the other presentation. We have people that are not insured, that can't afford health care, going to places like Grady every day for health coverage. We're drawing their blood. We should be testing these people. And I'm sure if you look at Grady numbers, and this is not towards you because you guys have been fantastic. Let me be absolutely clear. I appreciate what you do. These are sobering numbers, and we have to be able to discuss them openly. We have to be able to touch on them from what's truly impacting our community. And as an African-American male, I am just mortified right now that 71% of our AIDS cases in Georgia were Black people. I think it touches on what my colleague there spoke on: poverty, the lack of access to healthcare, and other issues in our community, which is why we must take advantage of every opportunity to test. If someone is coming to the hospital for treatment and we have already drawn their blood, why are we not using that opportunity to test for HIV and syphilis and everything else and all the other care? And I know in some instances we are, but we are losing a lot of opportunities too. Can you just talk about that a little bit for me, please?
Yeah, certainly. And I believe, and Jenna will correct me if I'm wrong, if I'm misquoting CDC, but I believe CDC's recommendations as far as HIV testing in an ED facility is opt-out testing, which is
They have to say
automatically-
that I don't want it.
Right. They have
It's
to
going to be
physically-
automatic unless they say I don't want
Right.
it. Exactly.
That's best practice. And I know our friends at GHA are here. I will get with them after to see if they could survey their facilities and let us know how many of their EDs are actually following that best practice recommendation. But with HIV specifically, that is a recommendation of CDC.
And we know Georgia's growing. I think Representative Silcox said that earlier, and she had a very, very good point. I mean, between 2010 and 2020, Georgia saw 1 million new people, which over half of them were Black people. Many of them are moving to the metro Atlanta area because that's where a lot of opportunities are. But when you have high volume, you're also going to have higher cases. And that's what we're seeing happening here. But this is disturbing. 71%. We got to do something about this. We can't sit back and continue to see this transpire like this, Madam Chair. We need to bring this to the forefront. And I think that everyone, regardless of your party, regardless of what part of the state you're from, you should be disturbed that one race is carrying this much burden of our HIV diagnosis. We're missing something. And we got to find out fast, or this is going to destroy our community. We got to find out something very fast. My uncle died of HIV. So I'm very passionate about this. And it happened when I was in 8th grade. I don't want to see another family go through that. We need to address this.
Yeah.
Thank you.
Of that 71%, what percent was Black males? Or about, I mean.
I will have to confirm that with you. I don't have that off the top of my head.
Okay. I think it would be a large percentage if I remember correctly, but I may not remember.
Yeah, it's similar. So it's still about 70%. Like if you look within those individuals who are Black or African American, it's still very similar to that kind of 70% are men and 30% are female.
And okay, in reading about it, and I've been following AIDS since early before other people weren't following it, thanks to a book called When the Band Plays On. I mean, they say one of the reasons, Representative Reese, in Black, or in African-American men is because the religion in the African-American community and the stigma against being gay or bisexual. And so there's a lot of not reporting it and not admitting that as one of the problems that we have. I guess we need a lot more education on that one.
And you're absolutely right. Growing up in rural Georgia with an openly gay uncle, I know exactly what you're talking about. I watched that play out. And I understand the challenges there. But how effective is the PrEP drug? PrEP?
We're getting to that.
And the reason I ask is because I see that a lot on social media. You hear that a lot within the conversations, and maybe there's this false sense that this drug is helping to protect the community. I don't know. I'll let you tell me what's going on there since we're getting into it before.
So I want to jump the gun. Dr. Paxton is going to be covering PrEP, but I can tell you that PrEP use is very disparate among the different race ethnicities. So it is utilized much more by whites than it is by Black or Hispanic and Latino. Yeah. Hopefully, Graham or Dr. Paxton can answer that.
Representative Hilton.
Thank you, Madam Chair. What's the average cost of an HIV test?
I cannot answer that for you. So the prevention and care is done within a different office than I'm in.
We can get that for you, but through public health, it's a relatively low cost.
What's the cost of PrEP treatment?
So PrEP, and we'll cover this as well. There's a patient assistance program. So for individuals who are uninsured, they can receive the medication for free. There is a cost associated with regular labs throughout the treatment period because they have to test to make sure that you're still HIV negative, your liver panels are good. So that is a unbudgeted cost, I would say, as well as a nurse to kind of oversee and manage care.
Yeah. On the testing, I just Googled. It looks like it's like $15 a test. It's not cost prohibitive by any means. Okay. Thank you.
Very much. With that. Okay. All right. And Dr. Paxton, if you can, I think we're all interested in preventing this. So can you spend most of your time on PrEP?
Yeah, well, actually, I lived and breathed PrEP for about 10 years when I was at CDC. I was the spokesperson for HIV pre-exposure prophylaxis and other things. We did not coordinate this to gear up all of these PrEP things right away. So I think thank you very much for setting the stage for me. And I apologize off the bat that I have, guess what? It's still cold and flu season. So please, keep that in mind. That's why I'm wearing a mask and I've got a cold and a little bit of laryngitis. So I apologize for that. Anyway, I am going to go ahead and thank you very much. I'm going to go ahead and talk about pre-exposure prophylaxis. Let me make sure I've got this. Okay. So let me remind, I'm just going to go do what we call a little prep 101 here. And, so we in public health live and breathe by one basic tenet, and that, an ounce of prevention is worth a pound of cure. And so pre-exposure prophylaxis, I think, is a real evidence of this. And I personally am very happy. As I said, I spent about 10 years of my life leading the CDC trials to see whether or not HIV PrEP worked. And so now it's great that, more than 10 years later, it works, and to actually see it put into place. But one thing you've got to remember, nothing works unless you take it. And so we'll talk, Graham will be talking about the access thing. So I'm here to tell you basically what is PrEP and to give you a little bit of information about that. And Graham will tell you about how to get it here in Georgia. So basically, pre-exposure prophylaxis refers to taking a medicine before you have an exposure in order to prevent that person from getting infected. And this differs from what some other people might have heard about as post-exposure prophylaxis. That's like your needle stick, like, a nurse or a doctor who gets a needle stick from an HIV infected person and then is given drugs to prevent developing HIV. That's post-exposure prophylaxis. Pre-exposure prophylaxis is taking the medicines before you have any such exposure. And high-quality clinical trials, of which I, help lead a number of them, have shown that when PrEP is used correctly, and I'll talk about what that means to be used correctly, it is phenomenally effective at preventing infection through sexual, and through drug use transmission. So basically on the level of 98, 99% for sexual transmission and for 74% for IDU. And in fact, what I can even speak to that for the injection drug use transmission, we did that trial in Bangkok at the time with tenofovir, which is just 1/2 of the drug Truvada. And it, even in that case, it was still almost 75% effective at preventing transmission. And so we quickly pivoted to then giving twice, giving the double drug. And but you can't really test that. And I'll explain why, because it often comes up as to why are these recommendations for specific categories of people. And I'll talk a little bit about that for those of you who are interested. But so who can benefit from PrEP? First of all, you have to be HIV negative. So that's why this is in bold. You have to be HIV negative in order to benefit from it. So the general guidelines for somebody who might consider taking PrEP is that they should have ongoing exposure. So either anal or vaginal sex, we just arbitrarily picked in the past 6 months. And particularly if they have a sexual partner that they know has HIV, and especially if that person has a detectable viral load, okay, then this HIV negative person might be a good candidate for PrEP. Or if they have sexual partners who they don't know what their HIV status is, if they don't consistently use condoms, and as we've been spending a lot of time talking today about STIs, is that we know that STIs and HIV kind of go hand in hand. So you're at higher risk. If you've been diagnosed with an STI in the past 6 months, you might want to consider pre-exposure prophylaxis for HIV. Now, if you're an injection drug user, if you have an injection partner who has got HIV or is of unknown status, or if you share needles, syringes, or any other kind of shooting equipment, then you might want to consider taking PrEP. And then we have special circumstances that, you might consider. Again, if somebody has taken multiple courses of post-exposure prophylaxis and reports continued risk behavior, then, again, this person might just think, okay, maybe we should put you on pre-exposure prophylaxis, okay? And if a special category is for women who are have a partner with HIV and then they're trying to get pregnant. So in addition, it's always a two-pronged thing that we would do. We would recommend that the male partner in this relationship should be on antiretrovirals, because getting the viral load down to undetectable is the best thing one can do. But in addition, we would say, look, we know you're having unprotected sex because you're trying to get pregnant. So let's do the double thing. Have the partner at undetectable and give the woman who wants to get pregnant PrEP to, sort of belt and suspenders kind of approach for that. So we have at the moment there are PrEP can be given either, but you can either use pills, or thank heavens now we also have an injection. The pills that we have, there are two that are officially approved for by the FDA. One is Truvada, and the other one is Descovy. Now, basically, the only difference between Truvada and Descovy is Truvada is it's a double drug. It is Truvada and emtricitabine. Descovy is an updated version of Truvada and emtricitabine. It has been formulated, has fewer side effects on the kidneys and on the bones and all that. So, and then the shot that we have is called Apretude, and it's the only shot that is approved for use as pre-exposure prophylaxis. It's given, every two months, and you'll see here that I've put down what the official approval is. Like for Truvada is officially approved for people who are at risk through sex or injection drug use, and Descovy is for people at risk through sex. So you might ask why is that? Why are you saying that you can use Descovy for sex but not for injection drug use? And why not for people who are assigned female at birth, but who are at risk for HIV? And it's simply a function of the way that the FDA approval process works, is that these approvals are based on clinical trials. Okay, so at the time that we were doing the original approval for Truvada, we did all the clinical trials with Truvada and or tenofovir. The thing is, though, if you're then going to, let's later on find out that there is you can modify the drug, make it a little bit better in some ways or another, then technically you have to do another clinical trial with that drug. And what's the problem? The problem is that, because you have shown that the first drug is effective, it is no longer ethical to do a placebo-controlled trial. You have to give everyone the effective drug. Okay. And what happens when you do that? As a researcher, well, I know this, your trial size becomes enormous because you're giving everyone a drug that is been shown to be 98% effective. And then you want to see whether or not this other one is the same or more effective. You're talking about such large things that it's practically speaking, you can't really do a trial of it. But so that's why you're going to find, though, that doctors will say, look, we have good evidence that this should work. We can't do a trial in it, but then you'll call it off-label use. Okay. So that's why what I put down, I'm taking a long time to put this down here, but I get asked this question a lot. Well, why don't you just test it again? It's because you can't. It would take too many people because you can't do a placebo-controlled trial anymore. But the important thing is here, we have 2 pills that are available for this, and we have one shot. The PrEP requirements is that the FDA approved PrEP use for the pills on a daily basis. So that's basically taking it every single day. And for the shots, taking it every 2 months. Okay. So the client has to be, obviously, you have to be HIV tested before you start PrEP, and you have to be tested at regular intervals while you're taking it, because what you don't want to have happen is for someone to, it's unlikely, but for someone to become infected while they're taking PrEP, because PrEP is not a full treatment course. And so if you're exposing somebody who has become infected to an inadequate dosage, then you risk inducing resistance in their virus. Okay, so that's why they have to be HIV tested continuously while they're taking PrEP. You need to counsel them about reducing their risk factors. And you've got to remind everyone is that PrEP is effective against HIV, but it doesn't do anything against syphilis or gonorrhea or chancre or LGV. So you have to continue to use condoms. And so for these facilities that where we provide PrEP services, there's a lot that we have to do. We have to assess the client's suitability for PrEP, and and to be able to come in for ongoing monitoring, we have to provide laboratory services. We of course have to provide the drugs, the pharmaceutical services, and a lot of behavioral and risk reduction counseling is needed. So that's kind of about PrEP. We can talk a little bit more about that if you have any specific questions, but now I'm going to switch into, so what happens if for those people who don't get, who still get, who get HIV? So how do we take care of them? We have the Ryan White program. I'm sure you've all heard of Ryan White. I remember hearing about Ryan White when Ryan White was still alive back in the 1990s. Yes.
We're losing people and we're at our time limit.
Oh.
Could I let you ask questions that we have for the PrEP? And if we finish this discussion and give you full time to bring us about the rest of it when we are in session in late November and early December?
I'm happy to sit down.
No, and when you feel maybe better, if where I can hear and you can, thank goodness my cold is over, but this is 12 or 13 days out, I can't hear anything. Okay, I think we need to do that because people have other meetings. And obviously, we're pretty interested in this subject, as you can tell from all the questions about it. That's okay with the department. We do it that way. Yeah, right. Okay, now, can the committee keep up with this? Okay, ask questions you have about PrEP preparation and the PrEP. No questions? Okay.
I don't know if I'm jumping ahead or not, but when you test and somebody is positive for HIV, do you also ask if they were taking PrEP or not?
Generally, that would be come up. But of course, once somebody's positive, we're really concerned there with making sure they get on antiretroviral therapy. So yeah, I mean, the question generally when you have a newly diagnosed person, you ask all sorts of things about the circumstances of the infection. But
I was just curious if we went back to the previous presenter, if that information was part of what you're tracking with the new cases, if that includes PrEP data.
So PrEP data is not part of any of our routine surveillance, but we have two projects. The Georgia Health Behavioral Survey and the Medical Monitoring Project, where they actually interview individuals. One is focused on people with HIV, and the other project is focused on people who are at higher risk for HIV. And they do get into questions about whether they were previously on PrEP or if they are on PrEP in those interviews.
I mean, now that there's an injectable, why would that makes you, immune to becoming HIV infected basically 98% of the time or whatever it was? Why would you take the pills?
Some people don't like injections,
Well,
or they
right.
want, it's because, different strokes for different folks. Some
Is
people prefer pills and others like injections.
But the trouble is you have to take the pills.
Yes, that's
And you
true.
can't,
Yep.
it's sort of like ladies who get pregnant
Mhm.
and, they forgot one or two or one pill and it was just at the wrong time.
Well, yes, and also there are, I mean, I don't want to skirt over too much. There are different things one has to do for somebody who is getting the injections. Like if you follow the letter of the recommendations, they are supposed to get a viral load, which is a more expensive test, like
Okay.
every 2 months or so. They have to come in. There's a longer tail off period if they're going to come off of the shots. You actually have to switch them over for a while to the oral pills because you don't want to ever leave them sort of uncovered. So, I mean, there are things that one has to consider too that I'm, didn't want to get into.
Is there a huge difference in the cost?
See, I don't know what the cost is. I don't believe there's a huge difference, but I'd have to,
Right.
I'd have to look and find
Will
out
you
what
look that one up? I mean, because I wondered if that
Sure.
would be it, for the availability and the cost of whether we do it. And in our PrEP program that we have going now, when we talk about it, Do we only use the pills?
No, they're both covered.
They're both covered and
Yeah. And
patients.
so
have-
the same thing that Megan talked about, in which there are assistance programs, they'll cover both the pills and for the shots.
Good. Do anybody else on the committee? Go ahead. You got him turned on. Representative Hilton.
Just referring to toward the end of the presentation here, it looks like there's a PrEP pilot program. Can you give us an update on that?
Well, you're talking about the PrEP pilot program in the northern part of the state, not in Fulton.
Yeah.
I forgot to mention, I'm the Fulton Health District Director, so I'm going to refer to Graham to tell you a bit more about that.
Yeah, absolutely. So Madam Chair, if you'd like me to come back later, I can do that, or, okay. Oh, now? Okay, excellent. Yeah, well, so I'll just move over to the slide that has some of the results of the PrEP pilot program here. So it happened in the Northwest Health District and the North Health District. These were chosen because of Haralson and Towns County being identified by the CDC as being high risk because of injectable use. So in this case, the North Health District launched 2 satellite PrEP clinics, one in Towns County and one in Forsyth County. In the Northwest Health District created a PrEP clinic at Haralson County Health Department, and also expanded PrEP screening services to the rest of the county health departments in that district. We ended up screening over 1,500 individuals, and there is a full update in your packets that gives a complete kind of breakdown of everything that happened during that program.
Well,
No, what was the result?
read the end of the book for us and,
Yeah, I mean,
and give us, we'll look at the other of it.
yeah, I think it was a certainly positive result. We were able to screen a lot of people and then get those who were qualified and interested on PrEP. So we consider it a success, and we hope to continue to expand. In next slide, the General Assembly provided extra funds to us to continue to expand. So we'll be doing that to ensure that every health district has a PrEP services in the district.
Okay. Are there other questions? I am so sorry, and Dr. Paxton, I apologize again for running everybody over, but I don't want to lose everybody. And I will schedule this. Megan, will you let everybody know? I appreciate all the hard work that everybody is doing with, something that's very important to our state, and trying to decrease the number on sexually, expanded diseases and HIV and all the other things that we are faced with, and not, are not hitting the goals that we would like to have in decreasing the numbers. And I would like to say that for you, those Kathleen Tehan is the person who literally drove me crazy until I gave her a date for this meeting, and who suggested for all of you to speak on the issues, so we can blame her for the scheduling for it. I really won't. She's a dear friend. She is down with COVID and is having severe long past complications from it. She is some better, but not great. But this is a passion with her, and has been with, especially with prevention of HIV. And so I appreciate, when I say driving me crazy, she was in Hawaii. Her husband was first there. And I will tell you that Kathleen, at one point, it was when HIV was very new, and there was actually a bill in the Hawaii legislature to put an A on people's forehead, and if they had AIDS. And they called in Kathleen, who was in graduate school then working on these kinds of issues. And Kathleen has an award from the state legislature for her effect in stopping that bill that was going to brand people with an A if they were AIDS. This was in the early 80s, and has worked on this ever since, and done a great deal of work ever since. So I really miss seeing her today, and I appreciate her. And it's certainly of interest of mine since the 1980s when I ran, and I'm sure the book is still out there if anybody is interested. It was done by a reporter who has since died from AIDS, but it was how the AIDS epidemic started and all about it in the early stages. It's called "And Then As the Band Played On." Thank you very much for everybody that presented, and Dr. Paxton, again, we'll see you in December. Thank you for being flexible. And thanks to my committee for being here today. Get your questions ready and all the things we'll go over it again, get an update and see where we go from there. And maybe, and everybody's presented it. If there's something like like Representative Reese said, that we could do in the legislature in the coming session, that we could actually maybe do to make a difference, have that proposal sort of ready for us from each of the ones that presented. Maybe pick out one thing that would help you or two at the most and see if we can make some changes during the upcoming session. Thank you very much. We're dismissed.